Now it's for Professor Mosaad Soliman to take the podium. He is proponent of the adjuvant mini phlebectomies rather than sclerotherapy.
Let's go through this kind of varicoses like truncal and extratruncular varicoses in the course of radiofrequency ablation, and how much does it affect the patient health and how it affects his daily life. And this truncular and extratruncular varicoses, not only the disfiguring feature of the patient, but also by the end of the day, all of the symptoms are the same if you didn't ablate this kind of varicoses. And in addition, the process may proceed to a worse situation, which is the development of primary venous ulcer. So how do we proceed for such patients with a truncal varicose or extratruncular varicoses while you are doing a radiofrequency ablation? First, we have to puncture the vein with a duplex guided attention, either above or below the ulcer, or sometimes the trans ulcer using the duplex guidance. And at this level, we start inserting an 8 French sheath and followed by the insertion of the caster to be positioned at the valve, the saphenofemoral junction, or 1 centimeter distal to it. And we have a study at this level that the 0 point or ablation at the saphenofemoral junction is as effective, and even it doesn't induce any kind of DVT in case of radiofrequency ablation. And followed by this is tumescence at the saphenofemoral junction, and this tumescence will ensure a very good distance of around 3 centimeters away from the skin, just to avoid any kind of burning. And while you are doing this, we will proceed with the tumescence to the site of the ostia of the phlebectasia, and starting with, you can see my hand here is just doing the ablation, and at the same level we are doing this kind of tumescence. To stop bleeding from the sites, we will do avulsion of these veins, and then by proceeding with the caster at the site of arrival of this phlebectasia, we have to ensure that the tip of the caster at this ostia, and at this level we go through the session with 3 cycles of the radiofrequency ablation. So at the sites of the phlebectasia, we don't do 1 cycle or 2 cycles, but 3 cycles of phlebectasia, depending on an ex vivo study that have been started. And we have noticed that in an ex vivo saphenous vein, when we do a single session ablation, the intima only is taken, and when we do a double session ablation, intima and media, and when we do a 3 session ablation, extension or even shoring of the vein, extending it to the sides of the tributaries, which means when you do avulsion of these veins, it doesn't affect at all the saphenous system because it is already disconnected. And we have confirmed this part by doing this kind of histological and pathological examination of all the affected segments, and pathologically it again confirms the same pathway of affection of the different levels. Following this, we start by doing phlebectomy at different levels from the different parts of the limb, and ending by total ablation of the saphenous system together with rapid healing of the ulcer. So you can say this a whole story of doing radiofrequency ablation together with phlebectomy with the least pathway. Thank you.